adnexal masses. Actually, one of the students from a couple of classes ago made me a mug that says this thing, so stay calm, don't overreact, as a tribute to the ovarian, our ovarian class and our adnexal masses that we need to know about. You will see these. So this is a review from actually kind of last set of classes, but you're going to need to know this for the future because you will see this. 24-year-old comes in having vaginal discharge, pruritus, she has thick white vaginal discharge. From there, you should already have your differential, right? Vulvovaginal region is erythematous, K-Mark has budding yeast. Do you have a question? 1. I'm going to go with 1, also known as A. Yep. Fluconazole, right? Fluconazole, 150 milligrams times 1 dose. That's all you need times 1 dose. You don't need prolonged treatment unless they come back with repeated episodes of candidiasis. So budding yeast is candidiasis. Metro, what is Metro for? This 500 twice a day for 7 days. BV, what is Metro's vaginal cream for? BV. Clindamycin, BV. Just like the test, right? 2 questions in a row with the same answer. Sometimes that happens. And then Titazole, what do we put that for? Trick. Yeah, very good. You studied good. All right. 57-year-old comes in with vulvar pruritus for 4 to 5 months. She's got this perineal skin or perineal skin, vulvar thickening. It feels like this tissue paper when you have a little traction on the skin. And it's perineal region and perianal region are both involved. What does it put the patient at increased risk for? Squamous cell carcinoma. That is lichen sclerosis, and that increases their chance of squamous cell carcinoma. Okay. When you either palpate something or abnormal, so you guys know that you usually can't palpate the ovaries, right? We talked about that. Usually cannot palpate the ovaries. So if you're palpating something in the adnexa, good for you, but also bad for the patient, right? So if you're palpating something or you did some sort of imaging because the patient came in complaining of abdominal pain or pelvic pain, and on that physical exam or on that imaging, you identify a mass, these things need to be in your differential for adnexal masses, right? And this is not all inclusive, but this is the most common things that you're going to see as far as adnexal masses are concerned. So we have things like follicular cysts, also called simple cysts. It could be corpus luteum. It could be a hemorrhage inside either the follicular cyst or the corpus luteum cyst. You could have germ cell tumors. Okay, most common of those is going to be a teratoma. And then cystoadenomas can also occur. I actually saw a young kid in Uvalde last year that came in, his mom brought him in, they were at the grocery store, and he had a seizure. So no other medical problems at all, brought him to the ER, and he could only look, he's like 4 years old, only look like to the left or to the right, that's all. He couldn't look anywhere else, just only to the right. Oh, man, this, this poor kid. So we do a CT of his head. He's got a giant tumor in his head. Giant tumor in his head. It ends up being a cystoadenoma. So I saw them several months later, saw mom, kid running around like crazy. I said, oh my gosh. I literally thought this kid was going to be gone, but I'm sure that that's cancer. She said, no, it was a completely benign tumor. It was a cystoadenoma. They removed it, and he does very, very well. A little bit of speech to my brother now. So cystoadenomas, we don't see them very often, but when we do, they can grow up to like 30 centimeters. I mean, they can become huge, these cystoadenomas. Okay? So that's one of the differentials we got to have. Endometrioma, we talked about that associated with endometriosis. That needs to be on your list. So if someone comes in complaining of the D's, then we want to think about maybe they have an endometrioma that's causing their adnexal pain. If they come in, history of PID, gonorrhea, chlamydia, they're running a fever, think about some sort of abscess or some sort of infection, so tubo-ovarian abscess, or even hydrosalpinx. Anybody heard about hydrosalpinx? So hydrosalpinx is scar tissue has developed from usually some sort of STI, and that scar tissue is gradually closing down the fallopian tube, and so now you get fluid that fills that fallopian tube, and on ultrasound it's going to look like a big tubular structure that's filled with fluid, not like proteinaceous debris like an infection, but just fluid in there from that scar tissue. Always, reproductive age females, we always need to think about ectopic as the cause of their adnexal pain, especially in the setting of positive HCG. They might have polycystic ovaries that they don't know, or polycystic ovary syndrome that they don't know about, and that certainly can cause some discomfort. These patients come in and they have multiple cysts in their ovaries, usually of varying size, and those cysts can decrease and increase throughout the menstrual cycle, the menstrual month, and that can also often have an intermittent pain. And then ovarian torsion. We do know that the ovaries are not specifically fixed in the perineal area. They do have broad ligaments and they have ligamentous structures that kind of try to hold them in place. But sometimes they'll get twisted around on the ligament structures, and associated with that ligament structure is artery and vein. Artery and vein, and so the ovary can twist. Oftentimes, what makes it twist? Do they know? Cyst. Something that makes it lopsided. Because normally the ovaries are very, very small, like the size of an almond or something, 3.5 by 4 centimeters or so. So real, pretty darn small. But if they have a cyst on them or something like that, it can cause it to become lopsided, and that can cause it to turn. We think about malignant or neoplastic problems. Yes, they can happen in even the young. So premenarche, 10%. But the majority of our malignant type features, our malignant adnexal masses are going to be in those postmenopausal patients. 50% of our patients that are going to have some sort of malignant process in their adnexa are going to be in the postmenopausal years. So you want to keep that in mind for those types of patients. Differentials. So you can do learn this any way you want on all these differentials, or you could try to use this mnemonic, CHEETAs. So cystoadenoma, cystoadenocarcinoma, very rare cystoadenoma that actually is malignant. Okay? We could have a hemorrhagic ovarian cyst. Again, that can be corpus luteum, can be follicular, but there's blood inside that cyst, which causes a lot more pain. Endometrioma for our first E, ectopic pregnancy for our second E, teratoma, which is that dermoid cyst, okay? Torsion, which we just talked about, and then something called theca lutein cysts. Now, theca lutein cysts are seen in patients that have high exposure to estrogen. So patients that might be undergoing fertility treatment, they'll get HCG, or not estrogen, HCG. They'll get HCG shots, and that high HCG levels is what can cause theca lutein cysts. Abscess is that tubo-ovarian abscess for our A. H is a hydrosalpinx or hematosalpinx. So we can have hydro, which is fluid in there, hemato then is blood in there, and then that simple cyst or that follicular cyst. So that's just an easy way of kind of trying to remember the differentials for the most common causes of adnexal masses. These patients can come in and be completely asymptomatic. Maybe this is an incidental finding because they came in for something else. They came in for lower abdominal pain. In your mind, you thought, oh, I think this might be appendicitis. So you do an ultrasound, or you do a CT, and oh, here is what it is. It's actually maybe associated with this simple cyst. Or they may actually have appendicitis, and by the way, they have a cyst, and they're not even symptomatic from the cyst. They could have dysmenorrhea, they could have dysgesia, they could have dyspareunia. That's in the setting of endometriosis. They could have pain in their lower abdomen, they can have pelvic pain, or even in their lower back, depending on the size of the cyst that we're talking about. Okay. Now that pain could be sudden onset, severe. This is the worst pain I've ever had. I was just sitting there and all of a sudden I had this pain. Okay. That would be more associated with something like an ovarian torsion or something that's ruptured that can cause it. Or it could be dull and achy. This has been going on for several days. Okay, I don't know what it is, but it's just not going away, which is what prompted me to come to see you. If they have a fever, we always want to think that is an infection, but people with tubal ovarian abscesses don't always have a fever. Look at their history of PID, history of chlamydia or gonorrhea. They could come with pressure or bloating, especially when we talk about those postmenopausal patients where they have an increased risk of this in malignancy. Those patients oftentimes just have really nondescript signs and symptoms. They'll come in with back pain. Yeah, you're 65, of course you have back pain. I'm 30 and have back pain. I'm not 30 either. Everybody has back pain, so you don't really think anything of it because the signs and symptoms are so nondescript. They could have abdominal vaginal bleeding, they could have infertility, especially in the setting of a hydrosalpinx or prior STI that's causing some scar tissue. They could have virilization. Virilization is what? More male appearing, so hair that's growing out, excessive acne. That could be associated with polycystic ovary syndrome. Okay? Or you also could have virilization with something like a Sertoli Leydig cell tumor. That's usually a malignant tumor, and that's a malignant tumor of the ligament or the stroma that surround the ovary. So very, very rare type of cancer for those patients. So we've got to get our history, past medical history, get a good GYN history. That includes reproductive history, sexual partners, when's the last time you had intercourse, protected or unprotected, ever have an STI, what were you treated with, how many days did you actually take the medicine, because maybe they have a partially treated STI. I saw that Saturday in the ER. Oh yeah, I didn't finish my medicine because I felt way better. Okay. Get the review of systems, weight loss, fevers, night sweats. Those are things you gotta know. Have you ever had this before? When was your last menstrual cycle? That's when we think about follicular cysts. They're associated with ovulation. So when was their last menstrual cycle? And then you can kind of figure out when they ovulated to see if this is a follicular cyst. We're going to use that normal OPP-QRST when we document the information that this patient is telling us. And of course, a reproductive age patient, we're going to do a pregnancy test. Urine HCG is just fine. If the patient is pregnant, then you'll want to alternately set a beta HCG because that gives us a level. And that will be really important when we think about ectopic. We have a specific lecture where we talk about ectopic, but in ectopics, if you have a lower HCG level, it doesn't mean they don't have an ectopic just because they can't see it. It depends on what the HCG level is. But you want to make sure that we assess for that. Okay? Vital signs are really important. If they're tachycardic or hypotense, that tells me that something bad, and this is not just a follicular cyst. This is probably bleeding in the belly somewhere. They shouldn't be hypotensive and tachycardic. They may be tachycardic from pain, okay, but hypotense, no. All right, so if they're tachycardic, blood pressure looks normal, address their pain. This is the time to give these patients legit pain medicines. Morphine is okay for these patients. You can give them Toradol, that's okay, but it's not going to help them in the next few minutes. Morphine is going to help them, and usually we'll give them IV pain medicines because oral pain medicines take too long for onset of action, 30 to 40 minutes. So IV pain medicines, this is the time to do that. You've got to watch them walking if you can. If they're in there like, oh, 10 out of 10 pain, and they're on their phone, or they're walking normally, it's probably not 10 out of 10 pain. So are they in obvious discomfort? Are they sitting there with their knees up to their chest? They don't want to move because they're so. Are they walking like they have peritoneal signs on the tips of their feet? Like that's what I did when I had appendicitis. I walked in the air and I was like, oh my God, something is wrong. And of course I went to the nurses I work with, and I told the nurse, I said, I'm telling you, because we had this huge get together at the lake. Too much drinking, too much eating, and I was like, I think I just got to go to the bathroom. I think that's the problem. But no. So I'm like, after hours, I think 9 or 10 hours, my stomach was killing me. I go in and I said, if this is gas, you better not tell one person that I was ever here. And luckily it wasn't. It was my appendix, and they took it out. But I was in obvious discomfort. They knew. So watch how they walk in. Watch their gait. Okay, do your physical exam. It should include a pelvic exam with a bimanual exam. Okay, especially in someone that's coming with pelvic pain, adnexal pain, lower abdominal pain, and they're not really concerned about an STI. We need to do a full exam on them. Maybe a rectal vaginal exam, depending on if they're just coming with pressure and fullness or postmenopausal, that may be that they have a big tumor that's now pushing on their rectal area, on their rectum. So you want to be able to feel for that. Feel their lymph nodes. Usually you can just do the inguinal lymph nodes and that's fine. Abdominal exam, lung exam as well, especially in an older person that you think may have cancer with metastasis. I would do CVA tenderness. That's part of my abdominal exam already, CVA tenderness. But some people put it in their musculoskeletal and they'll forget to do that CVA check. Imaging, ultrasound. Ideally, transvaginal ultrasound. That's going to be your primary means of evaluating an adnexal mass. Okay? It gives us information about the size of the mass. The radiologist will say, does this look cystic? Does it look solid? Is there mixed components? And the radiologist is going to give you that information. Are there septations? Anytime you see, doesn't matter the age, if you see something that says septations, that's bad. That is cancer until someone proves to you histologically that it's not cancer. So septations is bad. Free fluid in the pelvis can be concerning. Now, if on your order form you write down when the patient's last menstrual period is, the radiologist can often tell you then if they feel like this is physiologic free fluid or if the amount of fluid there indicates that there's a rupture or there's a bleed. Okay, so try to document their reproductive and their LMP history on your order to get this done. If we need to, we can do an abdominal ultrasound, meaning if the patient can't tolerate a transvaginal ultrasound, they're very young, pelvic anatomy is distorted because when they go to put the transvaginal ultrasound in, the probe in, they're hitting up against something like a big tumor, they'll do a transabdominal. Okay? Or if they're able to do the transvaginal, but they can't really see the entire mass because it's so big, they'll add the transabdominal to that. But for your purposes, it should be a transvaginal ultrasound for these patients. CT, MRI, PET scan, not in the initial evaluation. Okay, those things don't, if you happen to get a CT for something else, then that's great. But if you get a CT and that CT does not show an intra-abdominal process as the cause for this patient's adnexal or pelvic pain, but oh, by the way, I do see a cyst there, you order an ultrasound, okay? You order an ultrasound because the ultrasound is going to identify and tell us more about that cyst than that CT scan. The CT scan is going to think, oh yeah, looks like this kind of cyst, but you order an ultrasound after that to evaluate to make sure that there's no other abnormalities associated with that cyst that would be concerning. Okay, so CT of the pelvis, not really to detect our initial evaluation, but if we identify that there's something looks to be cancerous, okay, then we use that CT of the pelvis really to help us identify metastasis. Same thing with a chest X-ray to identify metastasis. Pelvic MRI, again, not typically you're doing something from the primary care setting. This is something that if they can't identify what the mass is, or if they have identified it, but they need that pelvic MRI for better clarification or classification, then they'll do that. Usually with malignant tumors, they'll do that. Overall, when we do pelvic MRIs as an initial tool, it doesn't detect what we're really looking for. We just want to know, is there something there or not, and what does it look like? Pelvic MRI is going to get us more about tissue surrounding that area. CA-125, you guys should have heard about CA-125, widely studied biochemical marker that's used, it's kind of our primary method that's used for screening for ovarian cancer. Okay? But the problem with this is that we like CA-125, especially if someone has cancer, we have concern they have cancer because it is elevated, about 50% of women, which means it's not elevated in 50% of women that have cancer. Right, so we can't go solely by our CA-125. Right? CA-125 can be elevated in otherwise healthy people in about 1%. So then we say, oh, I think you have cancer based on the CA-125, and oh, they don't have cancer. Okay? Other things that can elevate your CA-120, pregnancy, if they happen to be pregnant, if they're on the menstrual cycle, they can do it. Fibroids, uterine myeloma, that can increase your CA-125. Endometriosis. Usually endometriosis can put your CA-125 in the hundreds. Okay, so people who have liver disease can have it, pelvic inflammatory disease, or recently treated for PID. So there's a lot of things that can falsely elevate the CA-125. So why do we use the CA-125? We use the CA-125 in cases that are high risk for ovarian cancer. If we have a patient that on their imaging is very concerning for cancer, CA-125 doesn't help us. It helps our consultants. Because if we can get an initial CA-125 level, that helps them when they repeat that CA-125 after some treatment, it helps them to monitor treatment response. Because we don't want these patients getting a bunch of CAT scans every 3 months, because we know that's associated with radiation. Okay, certainly they can do ultrasound, and they will, but they'll add that CA-125 to it, really to help us identify how well this patient is responding to treatment. Other labs, HCG, we talked about, CBC, especially if they're hyposensitive tachycardia. We want to see what is their H and H. I don't really care so much about their white count unless they're fevering and they have a history of an STI, then I might. But really, white count doesn't help me. White count can be increased just because they have the ovarian cyst. White count can be increased because they have a rupture of the ovarian cyst. It could be infection. It could be cancer. So we just really are looking at their H and H. To make sure that their H and H is stable. Postmenopausal women, we think about adding an LDH or an alpha-fetoprotein. That helps us determine, is this some sort of germ cell or is this a malignant tumor? Both of those can be elevated in those subsettings. Your treatment is going to be, of course, based on the type of cyst that we're seeing. It's also going to be based on the patient's age. Okay, pubertal, if they're premenopausal versus postmenopausal, what is the size of that cyst? If the cyst is larger on that ovary, and there's a likelihood that that cyst is going to make that ovary lopsided, they may remove that cyst, because if they don't, it increases their patient's chance of having some sort of ovarian torsion or some sort of rupture of the cyst. And also, the patient's desire for reproduction. If they have not had babies, or they still want to have children, then they will typically try to leave the ovary. Otherwise, they may, in fact, do an oophorectomy, where they remove the entire ovary, especially in patients that have completed childbearing. And the types of surgical treatment depend on the issue. So they could do, where they just remove the cyst. Okay, they could do unilateral salpingo-oophorectomy, which is fallopian tube and the ovary. Okay, they can do an entire hysterectomy with bilateral salpingo-oophorectomy. Right, so hysterectomy with bilateral fallopian tubes and ovaries, depending on what the causative agent of the cyst is. All right, so let's go through a couple cases. You got a 23-year-old female comes in. So G1P1 means one pregnancy, one baby delivered. At least for our purposes for now, okay? Presents to the clinic with cramping pain, right pelvic area for the last 3 days. Last menstrual period was 3 weeks ago, was normal. Uses condom for contraceptive. Pregnancy test is negative. On pelvic exam, there's a 3 to 4 centimeter tender mass. So yay for you that you could find that. The remainder of the exam is normal. So lymph nodes feel normal, abdominal exam is normal, she has no urinary symptoms. We got to think about our differentials, right? So cystoadenoma, cystoadenocarcinoma. Could it be a cystoadenoma? So it's a type of germ cell tumor. Could be, right? She got a couple of days, it wasn't really acute in onset, so we can't take that off our list. Hemorrhagic. Does it sound like a hemorrhagic cyst? Hemorrhagic is like something is bleeding inside. Usually something has ruptured and it's bleeding. So you think that would be more of a dull or more, probably more sudden onset of pain for hemorrhagic, and more like, oh boy, this is really painful. Ectopic pregnancy? No, right? Because the HCG is negative, so that's off of our list. Teratoma, that's another germ cell tumor, could be, right? It's only 3 days, kind of a dull affair, so we can't take that off. Torsion, probably not torsion, right? Because it's not sudden onset. Thecaludian, she doesn't really have anything that indicates that she has exposure to high levels of HCG, so probably not that. Okay, so right now we just have cystoadenoma, we still have teratoma on our list. Endometrioma, does she have the D's? It's not in her history, so probably less likely. Okay? Could she have an abscess? She could. The same thing about fever, no STI history. Oh, yeah, it could be, but probably not based on what we know. Hydrosalpinx, which is no history, if they had a history of STI or some sort of fallopian tube surgery, something called that is causing scar tissue. Okay, so maybe not that, we haven't talked anything about that. And then a simple cyst, could this be a follicular cyst? Could be, right? Menstrual cycle was what? 3 weeks ago. Oh, there we go. All right, what do we got? What's the next step? Ultrasound. Ultrasound is our next step. No, none of the rest of those, no. Ultrasound. Of course, if it was endometriosis, maybe do a diagnostic lab, but other than that, the rest of those are no. So we do an ultrasound. Well, gosh, we get an ultrasound, and here it is. We have a 3.1 centimeter right ovarian simple cyst, a follicular cyst. Okay? No free fluid in the pelvis, no ascites, because if you have something that reports ascites in a person that does not have a history of liver failure, always concerning for cancer. So no ascites. So this is a functional cyst, okay? And the clue for that was her last menstrual cycle, last menstrual period was 3 weeks ago. So we kind of go back to that and say, okay, 3 weeks ago, now you're 3 days. When did she ovulate? When she ovulates, we have these follicular cysts or functional cysts. So functional cyst is a fluid-filled sac that forms within the ovary. And you're going to see this pretty commonly in reproductive age females because they originate from the ovarian follicles. Okay? So what happens is that ovarian follicle it doesn't completely rupture, and so fluid then fills in that follicle, and that's what causes the cyst. So the egg itself doesn't release the egg, so it doesn't rupture the outside of that, and so then the fluid comes in and fills the inside of that. You could have that, that's your follicular cyst. You could also have something called a corpus luteum cyst. Remember that the corpus luteum is primarily seen in our luteal stage. Typically lasts about 9 to 10 days. After that time, it degenerates. But here, for these patients that have corpus luteum cyst, that corpus luteum doesn't dissolve. It doesn't degenerate. It actually gets filled with fluid. And sometimes that fluid is clear fluid. Sometimes that fluid is bloody fluid. It's a hemorrhagic cyst. So patients that have just a corpus luteum with clear fluid, typically they actually have no pain at all. Usually, this is found incidentally because they came in for some other complaint and we happen to just see that. There's nothing really to do. Patients that have hemorrhagic cysts, and that's different. Anytime you think hemorrhagic or see hemorrhagic, that's more of probably a sudden onset of pain and something has ruptured. It can still be held within that cyst wall, or hypotensive tachycardic indicates that even that cyst wall has ruptured and now they're bleeding outside of that. How do you think those patients may present besides sudden onset of pain? Hypotensive tachycardic. How are they going to walk? Because you're probably going to have peritoneal signs. If you have peritoneal signs, peritonitis, how do we identify that? How they walk, we tap them on the bottom of your feet, right? You learn that in surgery, I suppose, probably. So they have actually peritoneal signs. They look like they do not feel well when they're coming in. Right? So the two types of the simple cyst, you're primarily going to see the follicular. That's going to occur a couple weeks after they have their menstrual cycle, associated with ovulation, where they ovulated, but an egg was not released and fluid filled that. That causes that vague discomfort. I don't know, it's just there, been there for a few days, doesn't seem to be going away. Corpus luteum, oftentimes asymptomatic, but that corpus luteum doesn't degenerate, but fills with fluid, and usually an incidental finding. These patients are usually painless. Hemorrhagic fills with blood, something has ruptured, and sudden onset of pain. Hypotensive tachycardic indicates that that whole cystic sac has probably ruptured. And those patients need a lot closer monitoring. Okay, so again, physical exam or their presentation signs and symptoms, pelvic pain, maybe dull sensation, maybe there's heaviness in the pelvic area. Oftentimes, we're gonna see this on one side, because usually we will ovulate from one side, not both sides, okay? And not associated with cycles. Hemorrhagic is gonna be much more painful, more severe, still unilateral, but sudden onset of that pain. What do we do? It depends on if they're premenopausal or postmenopausal, hemorrhagic or not hemorrhagic. So premenopausal patient, follicular cyst or simple cyst, less than 5 centimeters, nothing to do. Okay, typically that's going to go away over the next 1 to 3 months, and that's what you tell your patients. Okay? If they're 5 to 7 centimeters though, okay, 5 to 7 centimeters, follow-up ultrasound in 8 to 12 weeks. And our radiologists are really good about telling us that. Recommend follow-up in this time period, it's usually 8 to 12 weeks. If it's greater than 7 centimeters, GYN referral. Why? It makes it lopsided. Those big ones, ovaries this big, and now you got a 7 centimeters one. And so walking, running, sexual intercourse is going to cause that ovary to turn on itself, turn on its structures. And these patients are much higher risk for torsion or even intermittent torsion. Severe pain. I was there for a couple hours, went away. I haven't had it now in a couple months, and now it's back. So they can get intermittent. So you got to be careful. So those larger ones, they need GYN referral, and GYN can watch them. They can decide if they're going to do surgery or not, but normally they will do some sort of intervention to reduce that size. Okay? Now, so for those 5 centimeter ones, 5 to 7 centimeter ones, and even the larger ones, while they're waiting for OBGYN, give them anti-inflammatories. You can prescribe them NSAIDs as long as there's no contraindication. Ibuprofen, naproxen, any of those things work. And they remember they're prostaglandin inhibitors, and so they help by reducing the amount of prostaglandin, which is inflammation measures. Something that can prevent ovulation, right? If we're not ovulating, it's not likely, or we have a reduced chance of getting tested these follicular cysts. So give them something to prevent ovulation, something like combined oral contraceptive, something like birth control implant or Depo-Provera, depo-progesterone acetate. What about an IUD? No, why? Not consistent in preventing ovulation. So the IUD won't really work for these patients. You've got to have something, put them on something that prevents ovulation. That's the whole point of this, right? So anti-inflammatory, combined oral contraceptives, and the combined oral contraceptives are not going to get rid of the cyst that's there, which are trying to prevent additional cysts from forming. And that's why we're putting on this medication. So prevent ovulation, which helps reduce the chance of getting additional cysts. If they are postmenopausal, parameters change, less than 1 centimeter, they're good to go. Postmenopausal patients don't typically get a bunch of follicular cyst or simple cyst, right? They're not ovulating anymore, so it would be very unusual. So if they see them less than 1 centimeter, we're okay. 1 to 5, less than 5 centimeters. All right, here's where we go. You've got to, you're looking at doing a CA-125 in these patients. If that CA-125 is normal or that patient is low risk, okay? Low risk, meaning they've had multiple children, that decreases their risk of ovarian cancer. They don't have a family history. They're not smokers. That's all. Those patients are low risk. Okay, then we can do a follow-up ultrasound in 8 to 12 weeks to make sure. But if in 8 to 12 weeks we still have that cyst that's there, GYN referral. Okay? If that CA-125 is elevated, more than 30, or that patient is high risk, and they have had no babies, they are a smoker, then they need GYN referral. Greater than 5 centimeters, GYN referral. Can you still offer them anti-inflammatories for pain control? Sure you can. They probably don't need combined oral contraceptives or depo-progesterone or the hormone patch because they're not ovulating. That's not going to help, but you can still offer them the anti-inflammatories. Okay? And then a good portion of the literature nowadays says for these postmenopausal patients that come in that have a simple cyst, you probably should do a CA-125 on them, regardless of the size. Okay? But we definitely know between 1 and 5 centimeters and greater than 5 centimeters, CA125 should be in there. LDH, alpha fetoprotein, if we have concern for a germ cell, usually it would be a teratoma, or it's also increased in patients that have malignant masses, adnexa masses. What if this is a hemorrhagic cyst? Okay? Again, parameters change. If they're premenopausal hemorrhagic cyst, less than 5 centimeters, no follow-up. 5 to 7 centimeters, 8 to 12 weeks. If it still persists at 8 to 12 weeks, that hemorrhage, that blood should be dissolved by then. If it's not, then they need a GYN referral. Postmenopausal. So we say early postmenopausal. What does that mean? You may not remember, but first 4 years. First 4 years of menopause is considered early postmenopausal, and then after that, it's late postmenopausal. So first 4 years, the recommendation is CA125. Okay? If the CA125 is normal, then the recommendation is to repeat that ultrasound at 8 to 12 weeks. If that cyst, that hemorrhagic cyst persists, then GYN referral. And then late postmenopausal, greater than 4 years, if they're having a hemorrhagic cyst, they need a GYN referral for these patients. So there's a lot of parameters that you gotta be familiar with. So we have cysts, and size does matter. Okay, size does matter. 3 centimeter cyst versus a 10 centimeter cyst is going to change the management of these patients. 3 centimeter, I don't need to do much. 10 centimeter, I probably need to do something. Probably need to refer to this patient. Because I'm not going in there, you're not going in there managing it, at least in the long term. So short term, you can do some stuff. In the long term, these patients do. So this is a giant cyst that was removed. This is a fairly old picture. Actually, I think when I was going through residency, when I was doing my GYN rotation, this was an ovarian tumor that was removed from a patient that had not seen a provider in about 20 years. So she looked, obviously on physical exam, very large. She just looked like she was a fairly large woman. And she was, but this did not help, right? So you couldn't really necessarily tell that she had this giant ovarian tumor because she was kind of large, but this is what we ended up pulling out from her, was a big, giant ovarian tumor. So when you're evaluating these patients, though, they come in, lower abdominal pain, you got a CT, and you're like, oh, that's probably the cause. You've got a 1 centimeter little cyst. That's probably absolutely the cause of you writhing in pain and bending over and walking like you have peritoneal signs. No, probably not. Maybe it's an incidental finding. So you've got to make sure the size of that cyst correlates with your patient's physical exam findings, right? Otherwise, it might be an incidental finding. You hang your hat on this must be coming from this cyst, and you're going to miss something else. Maybe it's an infected kidney stone that's causing so much pain, but you happen to see that on an ultrasound that you did with this cyst, but you're going to miss this infected kidney stone. The patient comes back a couple of days later, you're all septic and dies, right? So you've got to make sure that the patient's signs and symptoms can be explained by the adnexal mass that you're seeing. Got to make sure that you don't miss anything else. Other GYN or non-GYN causes of their pain, right? And you need to identify, do they need emergent intervention? Do they need emergent consultation? Or is this something that you can manage at a primary care level, knowing you need to follow up and potentially at that point refer these patients? So case 1, follow-up. She comes back, she says, man, I feel so much better. Pelvic exams are remarkable. What do we want to do to help prevent reoccurrence of this cyst? Hormones? OCPs? Birth control patch? OCPs. Yeah, OCPs are probably good. Can we do the birth control patch? Yeah, we could. We could do birth control patch because it prevents ovulation. GnRH agonist, probably not going to help. NSAIDs, certainly we can give for pain, but it's not going to prevent reoccurrence. And then IUD, we've already talked about, will not prevent reoccurrence. All right, so case 2, we've got a 25-year-old female that comes in, fullness in their right lower quadrant for several months, has had regular periods, dysmenorrhea, no history of STIs. On exam, there's a full mobile mass in the right adnexa, 8 by 8 centimeters, again, good hands. ACG is negative. Transvaginal ultrasound is done. We've got our differentials, so you want to think through those. And this 8 by 8 been going on for several months, not acute in onset. Okay, I know what I got for my differentials. All right, we got an ultrasound. Ultrasound said, man, you argue it. It is, in fact, an 8 by 8 centimeter mass. And it's got these mixed, they compose of mixed and solid components. They're calcified areas inside this 8 centimeter by 8 centimeter mass. No ascites, and the left adnexa is unremarkable. What do we think? Dermoid cyst? Teratoma, right? Calcified, what is that? Teeth in there. My good friend had a teratoma, and I said, please bring it home so I can see it. We're not doing it. So yeah, likely diagnosis for this patient, probably a dermoid cyst, that teratoma. These patients will have these cysts for months and months and years and years and years that are slowly growing, slowly growing, slowly growing. So this person, 8 by 8 centimeter, luckily didn't have any symptom before. So this is going to be the dermoid or the teratoma is the most common solid ovarian mass, most common germ cell tumor that you're going to see. Again, slow growing. Oftentimes we'll see that between the age of 25 and about 54 years of age for these patients, but they can be seen in younger girls as well, especially if they've had them since birth. Anybody know like the wives' tale about where they come from? Suppose it's your twin that never fully developed. Well, I made the mistake of telling my best friend's mother that. Yeah, it was bad. She's like, they're from Virginia. What do you mean? What, she didn't have no twin? I said, no, I'm just saying like that's kind of a lie. I don't know what you're saying, Susie. I do not know what you're talking about. She never even had no twin. I said, forget I even said it. Never mind. Never mind. She's doing fine. Out of surgery. She's doing So, but that's the thought, is that they actually come from a twin that wasn't completely formed, and that's where these germ cell tumors come. Oftentimes, not often, but sometimes they can be bilateral. When they do that ultrasound, lucky for us, they will look bilaterally. 15% of the time, they can have it on both ovaries in these patients. And it's composed of these 3 layers of tissue. You got ectodermal, endodermal, and mesal layers. You got the sweat and sebation gland, you got hair follicles in there, you got teeth in there. Oftentimes 5 to 10 centimeters, but they can go up even higher than that. Okay? Usually by the time they're diagnosed, they're upwards of 10 centimeters because then the patients are having signs and symptoms. So this is what a teratoma, a dermoid cyst, looks like. This has got a nice little toupee on it. We've got some teeth over here. Okay, the other one's got some teeth. Teeth, yeah. So you see why I wanted her to bring it. What do we do? It depends on the size, depends how symptomatic the patient is. They can do an oophorectomy where they'll remove the entire ovary, or and usually they don't do just the dermoid. Usually it's kind of really involved inside that ovary and it kind of takes over the ovary, so most times it's going to be an oophorectomy. They can occasionally, if it's small enough, they can do a cystectomy where they just remove that dermoid cyst. Usually that is done via laparoscopy nowadays, but if it's very large, then they'll have to do an open lap. For premenopausal patients, if it's small, it doesn't bother them that much, they don't want to have surgery now, there's nothing wrong with watching and waiting and doing a repeat ultrasound, in 6 to 12 months, and telling the patient to come back if it's worse. Usually we recommend that it's less than 5 centimeters because it decreases the chance, or it doesn't decrease, but there's not an increased risk of torsion. Anything greater than 7, we think about an increased risk of torsion. As we've got repeat ultrasound for these patients, again, if they decide not to do anything, we got 3 to 4 months, and then oftentimes, as long as it's stable, then you can kind of push that out to 6 to 12 months. You don't have to do it every 3 to 4 months for the rest of your life, right? You just want to make sure that there's nothing growing there. And postmenopausal patients that have dermoid cysts, they need GYN referral. All right, let's take a break. See my department. She had a sudden onset of left lower quadrant pain. It started 2 hours ago. Sharp, comes in waves. She has nausea, vomiting associated with it, and she has tenderness of her left adnexal area, fullness. She has rebound and guarding. A previous transvaginal ultrasound showed a 7-centimeter ovarian cyst. Okay, so think about your differentials. If something causes a sudden onset, and based on these answers, what do you think is going on? Ovarian torsion. Ovarian torsion. Probably so, right? Sudden onset, because out here if we have hemorrhagic, that's possible. Ruptured ovarian cyst, probably less likely because otherwise it's stable. And she has a history of 7 centimeters. So transvaginal ultrasound shows no blood flow to the left ovary. So it is turned on its ligamentous and vascular supply, twists, and the patient was taken to the OR, and that's what they saw on the lab. So of course this is the ovary down here, which is normally white in appearance. You can see a little bit of white here. This is the ligamentous and the vascular structures were just turned on. So again, that cyst right here makes that ovary lopsided, and just walking or running or aggressive intercourse can make that ovary turn, and these patients can have ovarian torsion. We're going to think about ovarian torsion then as usually sudden onset. Now, it could have been sudden onset now, but you want to ask about a history as well, because sometimes they'll have a history of, yes, this has happened to me before, exactly like this, lasted a few hours or lasted several hours, but I didn't go see anybody, and then it went away. But it's a rotation of the ovary on its structures. Sometimes it's just the ovary, sometimes it's the fallopian tube as well. So the whole side could be involved. It can occur during pregnancy when the ovaries are a little bit larger because of the increase in estrogen. Up to 80% of these patients will have some sort of mass. And then we think about the size, so anything greater than 5 centimeters could cause a torsion, but OBGYN is really, they kind of dig their heels in and say, well, in fact, it's less than 7, it's probably not going to happen. But it does happen. So the book answer is greater than 5, but the OBGYN folks typically won't do much about it until it's about 7 centimeters. But emergency, this is an emergency. These people can't go home. It's really important that even if they come in and they say, I'm not in pain now, but I was in so much pain a couple of hours ago, I couldn't even stand up. I waited until after the pain went away, and then I came in, you need to be thinking torsion. You need to be thinking torsion on that, because it can torse and detors. You guys learned about that in GU with the testicle, right? The testicle can torse and detorse. The difference in the testicle is external, so you can just reach down and move back around, right? You can't do that with this. Okay? They've got to go to the operating room, and they've got to detorse this in the operating room. Right adnexa is more commonly affected because the left one has a sigmoid colon, and so that kind of helps kind of keep it in its place in the correct spot. Even though they're not specifically pinned down, it kind of helps keep it in that spot where it's supposed to be. So sharp lower abdominal pain, usually one side or the other. Sometimes the pain is so bad they can't tell you what side it is. I don't know, it just hurts all down here. Sudden onset, and then it typically gets worse over hours, and sometimes all of a sudden it just goes away. They can have radiation to their flank, to their groin area, even down to their thigh. A lot of times on exam you may not feel a mass, but they will be tender on the affected side. And then rebound or referred lower abdominal pain. You push on one side, it hurts on the other side. They can have a low-grade fever that's associated with it. So low grade, so 101, okay, that's still a fever, right? They can have 99. But when they have that, it's more, more worried that they have necrotic tissue that's associated with this as well. Nausea and vomiting, because it's so darn painful, these patients often will have nausea and vomiting because of the pain that's associated with torsion. Transvaginal ultrasound really depends. You can get partial torsions, you can get complete torsions, then you can have fallopian tube or just the ovary that's involved. But oftentimes they'll do a Doppler to look for blood flow. And they'll document on there if their blood flow was seen or if it was not seen. Again, just because they don't see or just because they put on there that blood flow is seen doesn't mean they didn't have torsion. Maybe it corrected itself. So if on that ultrasound it shows a large cyst, now the patient feels okay, but they had severe pain, that's your indication, that's your clue that there's something that caused it to torse. So normally you're not going to see ovarian torsion unless they have some sort of something anatomically that's caused that ovary to be lopsided. But part of the other thing that they'll look at is, because this can mimic an ectopic, you need tube ovarian abscess, they can see all of that with our blood work, our HCG, that's negative. Usually they won't even take it to ultrasound until the HCG comes back. And then they'll look to make sure that this is not a hemorrhagic ovarian cyst, or is there anything that suggests that this might be an infectious etiology. Okay? An endometrioma can rupture any causes as well. So ultrasound is going to be our ideal way of evaluating these people. CT, maybe you did a CT because they came in with low abdominal pain. Okay, that's possible. MRI, no. Unless it's a very young person, and you're doing the MRI because you think it's appendicitis, usually they'll do an ultrasound first, and then they'll do an MRI because they don't want to radiate those kids. Otherwise, you don't use CT or MRI for initial evaluation of pelvic pain disruption. How is this treated? If they can, they would like to save the ovary. But if there's any evidence of necrosis at all, they'll take that ovary and maybe they'll take the tube as well. If they can save the ovary otherwise looks pink like this one, then they'll detorse it, they'll remove the cyst, and then they'll affix that ovary to the broad ligament so that it reduces a chance of ovarian torsion in the first place. Case 4, 32-year-old female comes in, routine annual exam. Okay? She has no complaints. She does say, I had a chlamydia infection a couple years ago, successfully treated, I haven't had any symptoms since. An exam, there's a 4 by 4 centimeter adnexal fullness. The rest of the exam is normal, pregnancy test is negative. Transvaginal ultrasound is ordered, and in that transvaginal ultrasound order, we're going to say history of STI, test of fullness, and these are my differentials, right? So again, no complaints. Well, that tells you a lot, right? It tells you probably an HCG is negative, so ectopic is out, hemorrhagic cyst is out, ovarian torsion is out, as long as she doesn't have any history. Fecal lutein could still be in, but she doesn't have anything to say that she's not exposed to high levels of HCG. Abscess, probably not, she's asymptomatic, and she said a couple years ago for the chlamydia infection. All right, so what are you guys thinking? Could still be like a corpus luteum cyst, right? Could be asymptomatic, okay, but it doesn't really explain the fullness necessarily. So we think we get an ultrasound, and this is what the ultrasound, a tubular structure that's adjacent to the ovary. The ovary itself appeared normal, no pelvic fluid, but you've got this tubular, what is that tubular structure? Probably a fallopian tube. Why does it look tubular? Full of fluid, and we got scar tissue. So it's normally you're going to have fluid, transulated fluid in and out of that fallopian tube. It's going to be there. Well, now you've got scar tissue. Over time, it makes that opening at that fallopian tube smaller and smaller and smaller to the point where it completely closes down. So this patient could not only, they could have also come in with a complaint of infertility because they don't have that fallopian tube is not functioning. Now the other one is not just, but because they have that scar tissue, now that fluid backs up. Could be menstrual cycle fluid that's backing up in there as well, because we do get most people have retrograde menstrual cycle, menstrual fluid. But either way, the fluid is in there and it's causing, looks like a big sausage, essentially. It's clear and sometimes some bloody fluid that's in there. But no free fluid in the pelvic, and her main reason, the main reason why she got this is that chlamydia infection 2 years ago. Okay? especially if it went for several weeks or several months before it was identified as an infection. So now we think about our most likely diagnosis based on that ultrasound, right? I think someone had already said it, but hydrosalpinx, so fluid in that fallopian tube. Fecalolysis, dermoid, rupture ovary, the ovary itself looks okay. It's just that tubular structure, just the fallopian tube. So fallopian tube tumors, the tumors themselves, neoplasm of the fallopian tube are pretty rare. Usually if you see something like a hydrosalpinx, it's going to be involving either a history of PID or a history of STI that has subsequently caused scar tissue. Okay? Even a history of ectopic pregnancy can cause scarring of that fallopian tube, especially if you had some sort of rupture of that fallopian tube. A lot of times if that's the case, or if they have to go in and make a decision in the fallopian tube and remove that ectopic, then they'll get scar tissue. Anytime you have a procedure to the fallopian tube, it increases your risk of scar tissue. Okay, but a lot of times, well, for us, we're going to see this because of an old infection, gonorrhea, chlamydia, PID, or even endometriosis with pelvic adhesions can cause this. Symptoms is more either asymptomatic, you found it incidentally, or yeah, I occasionally do have this kind of aching lower abdominal pain. Okay? Pain typically seems to be worse around the time of menstrual cycles. That makes sense, right? Because if you have retrograde bleeding that's going into that fallopian tube, the end of that fallopian tube is scarred down. Well, now every time you bleed into that fallopian tube, it's going to get bigger. And then once the bleeding stops, it's going to get smaller. So it makes sense for it to happen around the time of menstrual cycle. Diagnosis is usually not physical exam, it's going to be that ultrasound. Transvaginal ultrasound is typically how this is going to be diagnosed. Laparoscopy may be if you're in a situation where they see enlargement of that fallopian tube, they're not exactly sure what it is, you'll send in the OBGYN and they'll take those patients to the operating room to try to figure out what it is. Is it a tumor that's causing this, or is it actually scar tissue from prior STI? And then treatment, it could be a salpingectomy where they will remove the tube, or salpingoscopy, where they will make an opening of the tube or make a slit in the tube, take that scar tissue out and sew it back up. Anytime you touch the tube though, it increases your chance in several years from now from them developing this once again. So a lot of times these patients end up in a salpingectomy, especially if childbearing is completed with an infection. What happens if your patient recently had chlamydia? Okay, now it's fever, lower abdominal pain, pelvic exam, that copious vaginal discharge, cervical motion tenderness, unilateral adnexal pain. How does that change your differential? PID, right? And if you have adnexal fullness and associated with PID, what is that probably in our differential of things? Probably a 2 ovarian abscess. Probably an abscess that now has developed. So you've got that lower genital tract infection with an STI that became an upper genital tract infection with PID that has now gone into the uterus out to the fallopian tubes, or around the other way, the outside of the fallopian tubes and in. And now you have an abscess in that fallopian tube area. Could be right where the fallopian tube meets the uterus, or could be at the distal part. Okay? But infection or inflammation of that fallopian tube and oftentimes associated with the ovary a little bit as well. Usually to a lower and then ultimately an upper genital tract infection. These patients have lower abdominal pain, fever. Maybe they were recently treated or still on antibiotics for chlamydia. We saw a patient in BAMC like 3 weeks ago with this. She got diagnosed with chlamydia like on a Tuesday. She was in on a Saturday. She's like, I am not better, I am fevering, and she ended up having 2 ovarian abscess and had to go to the operating room so they could drain the abscess. So diagnosis for this is with that ultrasound. And then if the ultrasound doesn't really tell you, then that is the time you bring in usually a CT abdomen pelvis, typically not a pelvic MRI, and laparoscopy, very, very rare unless they just can't figure out what's going on. The CT abdomen pelvis would be warranted in this case if the ultrasound didn't give us a diagnosis. If this ruptures, these patients are going to be super sick, and they have a high mortality rate if this ruptures. So we've got to try to identify this early on in the course, so you can be treated with the appropriate antibiotics. We know for STIs and PID, we can do oral antibiotics. This is hospital admission with IV antibiotics. And then ultimately, they'll give them a couple days of antibiotics. If they're still not getting better, they'll take them to the operating room, and they'll IV in the operating room. Okay, so you've got a 35-year-old female for our case 5, comes in, underwent fertility treatment about 8 weeks ago, underwent fertility treatment, is now 8 weeks pregnant, and she comes in because she's having abdominal pain and pelvic pressure. Okay, so fertility treatment, HCG level is high, 250,000. Even if so HCG levels are highest at the end of the first trimester, and then they go down a little bit and then they plateau. So even first trimester HCG level is going to be higher than 37 or 38 weeks, okay? Because the placenta is not formed, and the trophoblast is taking out this HCG, right, to do what? Keep the corpus luteum around until the placenta can be formed, right? So high, really high levels. But 250 at 8 weeks, that's high. You know of anything else that could cause really high levels of HCG? Molar pregnancy, or a tumor, maybe, HCG producing tumor, or molar pregnancy causes. But this lady, even fertility treatment, this is not uncommon for them to have super high levels. They'll get HCG injections for the infertility. So super high. Transvaginal ultrasound shows multiple cysts on both ovaries with bilateral enlargement of the ovaries. Here's our differentials. What you thinking? Ectopic. Okay. Could be. Polycystic ovaries. Got a lot of cysts in there. Fecal lutein cysts. Here's your choices. We'll say ectopic, probably not. You say fecal lutein. Anybody else say fecal lutein? Who says PCOS? In the setting of pregnancy. Would PCOS cause an HCG level high? No, probably not. And a lot of times PCOS, they can't even get pregnant. So they would be happy to have an HCG level high, right? But no, but fecal lutein specifically in association with high levels of HCG. And these patients will come in to the clinic to see you because they've been treated by the infertility clinic. They're on all these medications. It's a Friday at 4 p.m. They've been closed since noon because they get paid too much money to work Friday afternoon. So they're coming to see you in the clinic. Yes, I know I'm supposed to go to see them, but you're the only one here. What do I do about this bad abdominal pain that I'm having? And I have, I'm pregnant and I had all these HCG shots. So for these patients, it's going to result from these really high levels of HCG. Usually from fertility treatment, can be from a molar pregnancy or gestational trophoblastic disease. You can also get high levels in a multi-gestation pregnancy, right? If you have 6 kids in there, your HCG level is probably going to be high. Probably not 250 high, but it's probably going to be high. So people that have multi-gestation pregnancies can get a degree of fecal lutein cysts as well. Usually they're going to come in with bilateral adnexal discomfort, bloating, and some of these cysts can become very large, greater than 30 centimeters. 30 centimeters. The ovary itself, 30 centimeters. That's huge. That is really, really big. And it looks like if they had no other risk factors, it looks like polycystic ovary syndrome. It looks like polycystic ovary because that's what it is. But now we're talking about really, really large cysts within the ovaries, or the volume in the ovaries themselves is a big volume causing the ovaries to be really large. Many times, these patients won't have symptoms at all. They have no idea they have it. They're not going to come see you or anybody else, right? But in a person that is in a setting that they have a potential for high HCG levels, if they come in with abdominal pain and bloating or pelvic pressure, you've got to get that HCG level. If you're in the clinic and that HCG level is high, you've got to send them to the emergency department because they need to be evaluated. Because you can't usually do an ultrasound for you guys. If you can do the ultrasound, and on that ultrasound it says theca cyst, what's the treatment? You got to take them off. If they're still on fertility treatments, they come off the fertility treatments. You've got to remove the HCG. Now, if this person's pregnant, it's just about managing their signs and symptoms because you're not going to remove the pregnancy. They went through a lot to have this pregnancy, right? You got to manage their signs and symptoms. There's no quick solution for this. But if they're undergoing fertility treatment, they're not yet pregnant, then the treatment is to remove that. So sometimes they will reduce the amount of fertility treatment they're on, and sometimes they'll take them off their company. That is not usually within your wheelhouse. That's usually something that you'll have to refer them to their fertility clinic for. But you've got to remove whatever. So if it's coming from a molar pregnancy, they'll do a DNC. They'll go in there and scrape all those trophoblastic cells out, and they'll get rid of the nidus, the source of that HCG. Okay, we've got a 26-year-old, or 28-year-old that's coming in, G0P0, meaning no pregnancies, no deliveries, coming in for sudden onset, right lower quadrant pain, started after having intercourse, history of ovarian cyst, not using any contraceptive method, and she has right lower quadrant time is on exam, pregnancy test is negative, transvaginal ultrasound shows free fluid in the pelvis. What are we doing? Sudden onset, free fluid. Something has ruptured, probably, right? Where'd that fluid come from? Something has probably ruptured. Maybe a ruptured, some sort of rupture or hemorrhagic cyst, cyst ruptured. Some sort of cyst has ruptured, right? Here's our diagnosis. Or something has ruptured, right? What do we have on here? Pregnancy test is negative, so probably not a ruptured ectopic because HCG is negative. But out of these ones, probably all going to agree that's probably a ruptured ovarian cyst for these patients. So ruptured ovarian cyst more common in reproductive age females because they are ovulating. And you can have release of just cystic fluid, or they could have blood that's associated with it. They're both painful. Both of them are going to be painful, but if you have blood, they're usually, or they have a potential to continue to bleed, and those are the hypotense, tachycardic, need blood transfusion people. Increased during ovulation, or if they're on ovulation induction medications, we could have increased risk of these ruptured well because the cysts get larger and then they rupture. And then, of course, we already talked about if patients are on combined oral contraceptive or anything that reduces ovulation, then we can actually reduce the chance of these rupture, which is why we see functional cysts. It's important to consult, to talk to our patients about ways that we can minimize the likelihood of them getting these cysts back. Right ovary typically most affected again because that left side is protected by the sigmoid cord. Usually, if it's ruptured, they're not asymptomatic. Okay? Occasionally, they'll come in and say, I just had a little, like some people have really super high pain tolerance. So they come in and have a little bit of discomfort, but not much. But most times, they're going to come in kind of writhing in pain, as if it was like a kidney stone. So that's also one of your differentials for these patients. But usually severe pain came on all of a sudden. Some sort of aggressive exercise, or they're having intercourse when it happened, something that caused that. They really don't know why cysts rupture, but for some reason they do, and usually it's associated with some sort of aggressive exercise or intercourse. For these patients, they usually will come in because the pain is so unbearable. They'll try warm compresses initially, and then they'll try to get up, and they'll try to lay down, and if the pain is just so unbearable, usually they're within an hour or two, shortly after this rupture. On exam, so this is a picture of a laparoscopy. Obviously, you've got your ovary, and then this is all blood that is in the pelvic cavity. they have to go to laparoscopy. So these patients can lose a decent amount of blood that's associated. Here, we also have the ovary, and we have a ruptured cyst, and this can be contained, and if so, these patients will still have pain and maybe nausea and vomiting, but their vital signs will be a little bit more stable. And so we gotta think about our physical exam. We've got to look at those vital signs. They can be normal, especially at the beginning. They may have a low-grade fever. Anybody that has evidence of hemodynamic instability, like tachycardia or hypotension, those patients obviously need to stay. So you got to do pretty aggressive management. Sometimes fluids, sometimes blood products as well. So if they come in, sudden onset of pain, hypertensive, tachycardia, we're already behind the power curve a little bit, because most of the time in healthy people, it takes a minute for them to become hypotensive and tachycardia. It's not something that happens within 5 minutes. They have to have a decent amount of blood loss for them to have those subsequent vital sign changes. On your abdominal exam, they may have peritoneal signs. Oftentimes it'll be diffusely tender in the lower abdomen. But what you want your patients to focus on is, I understand that you're tender everywhere, but try to really tell me, are you more tender on the right or more tender on the left, and pushing that area. We're going to get an ultrasound anyway, as long as they can leave the department, right? So where do people go to die? Radiology. All the radiologies. That's where they go to die. And so most of the code blues that we see here in BMC, code blue to the radiology suite, code blue to the MRI suite, code blue to X-ray. That's where they go to die. So if they're tachycardic hypotense, that creates a problem. You've got to stabilize them before you can get them to a radiology area. And most of the time, we have CT in our ER, but most of the time that's not the case. They're going outside of the ER to go to CT, outside for ultrasound. And if that's the case, and you're kind of like, I don't know, you got to go with them. Someone has to go with them to keep an eye on them. Okay. Pelvic exam, if you ever do one, a lot of times you will be able to identify which side is more tender for those patients. And they may have cervical motion tenderness, but no discharge, no STI concerns. Okay, and that's all because of the amount of bleeding or cystic fluid that they have that has been released that's causing those secondary physical exam abnormalities. Okay, for labs, HCG, of course, CBC, maybe a CBC now, and then probably a CBC in a couple of hours from now, right? Especially if you're at the point where you're like, I don't know. I think this patient is otherwise pretty stable, vital signs are stable. I'm going to repeat that HCG or repeat that CBC before I'm sending them out. I want to make sure that their H&H is stable, because the last thing we may see is a decrease in the blood pressure and that tachycardia. So HCG, CBC, type and screen, and maybe a type and cross if they come in hypotensive tachycardic, because we'll put them for the last couple hours. And they type and cross, remember, they hold the blood for the patient, they're going to send it up to you. If they have a fever, certainly they could have a couple of things. They could have a ruptured cyst and an infection. So if that's the case, you want to get their history. And if so, then certainly STI screening is not out of the realm of the labs that you can do. But CA-125, typically not beneficial for these patients. Can be elevated falsely because of the cyst itself or the rupture of the cyst. What do? We do a transvaginal ultrasound, ideally. Okay, pretty sensitive for this type of thing. Usually we'll say that it has free fluid in the, and sometimes the radiologist won't necessarily see a cyst, but they'll see indication. They'll see that free fluid, and by seeing that free fluid, they say suggest, follicular cyst rupture or focus lutein cyst rupture. That's kind of what they're suggesting. And then again, we think about CT, probably not beneficial. MRI, probably not beneficial in the acute setting. You want to be able to see that Adnexa, and the best way to do that is with a transvaginal ultrasound. The other good thing with that transvaginal ultrasound, the radiologist can tell us, does it look like there's blood that's in there and coming out? Does it look like just clear fluid? Like what, cystic fluid? What does it look like? And they can be able to tell, they'll tell by looking at the, I don't know what it's called. Is it Hounds units? I think it is. Yeah, Hounslow units. It's in there somewhere. Hounslow units, they can categorize that if it's blood or cystic fluid. if they come in, low abdominal pain, otherwise hemodynamically stable, okay? Control their pain, observe them for a couple hours, consider repeating that H&H to make sure everything's okay, and they can go home. They can go out with pain control, with quick follow-up with you in a couple of days to make sure that they're still doing okay, right? So if it's complicated though, meaning they're hemodynamically unstable, pain is not controlled, ultrasound has a bunch of free fluid in the pelvis, H&H is decreasing, now we have to resuscitate these patients. Maybe fluids, maybe blood products, almost always a consult to OBGYN, or if you're in an area that doesn't have that, it would be to general surgery, and they oftentimes have to bring them in for monitoring. Okay? And then ultimately, these patients may go to surgery in the next few hours. Sometimes they'll go to surgery from the emergency department or the clinic, sometimes they'll monitor them to see if that bleeding will stop on their own. But surgery indications, if they're hemodynamically unstable, okay, and that persists, if they have evidence of ongoing blood loss, we're going to identify that with our CBC. If they have any evidence of infection, or if there's malignant and they're bleeding and unstable associated with that, then oftentimes we're taking the surgery for management. We got the same thing here. We've got ruptured ovarian cyst management. So is the patient stable or not? That's our number one thing. Is stable or not? If they're not stable, okay, is there evidence of ongoing blood loss? H&H, repeat the H&H. If you send them out of the hospital without a repeat H&H, you're really asking yourself to be calling the fours for that. Right? You're calling the lawyers to help and save you. So you've got to be able to monitor and observe these patients with repeat vitals and a repeat lab. If there's no evidence of ongoing blood loss, okay, and there's no infection, no malignancy, then they can go home. Okay? But anything else on the yes side, oftentimes these patients warrant admission to the hospital and management from our consultants, not from us. Okay, so now we've got almost done. 42-year-old female comes in. She has a history of dysmenorrhea, dyspareunia. She's had chronic pelvic pain for the last 3 to 4 years. She's got diffuse lower abdominal tenderness on exam. Speckling exam was painful, but otherwise unremarkable. HCG, urinalysis, STI, all negative. What is our differential for this patient? We got those same differentials, right? When we think about this, she's got the D's. Got what we already said, probably endometrioma. That's what I would think if we can be able to get this history. So if you think that patients come in to see you and say, oh yeah, I've got painful menses, I've got painful this, I've got painful that, they don't tell you none of that stuff. They don't tell you nothing. What are you here for? I've got abdominal pain. Okay, when did it start? I don't know. Like yesterday or 3 days ago? Yeah, I think so. Yesterday? Yes or no? I mean, it's like pulling teeth. It's like if you have teenage children, teenage kids, and they come home from school. How was your day? It was fine. Did you do anything? No. Nothing. Did you do homework? I didn't have any homework, Mom, in school. Did you do work? I don't know. You don't know what you did today? You spent all day in school. That's how I'm talking to these patients. Talking to these patients, you're like, oh my gosh. So they're not going to tell you all this, but if you were to be able to get all this information from them, and we have these as our differentials, probably I'm betting on maybe an endometrioma. But could it be a ruptured ovarian cyst? Probably not. It's been going on too long. Dermoid cyst, maybe still. You still have dermoid cyst, especially if it's big, right? Because it can cause some of these signs and symptoms. Hydrosalpinx, ovarian cancer. How old is the patient? 42. Ovarian cancer could be on there as well. So we've got our differentials, and if we have the D's and we think about that, an endometrioma, we're going to do our ultrasound, and that's going to help us really identify what's going on. Endometrioma, you can have in those endometrial cells that can go everywhere, we know, but you have these cystic lesions that develop in those cells. And they are chocolate appearing because they have old dry blood, so they're brown in color. And the radiologist can identify them by identifying probably varying degrees of blood from fresh blood to old blood inside those endometriomas. They know how to do all that. So they will tell you on your report consistent with an endometrioma. They can typically pick this out pretty easily. But really, we've got these degenerative blood products inside these cyst cavities, and those are endometriomas, specifically associated with endometriosis. Okay? So if someone comes in, they've got endometriosis, that is your sign right there that they got endometriomas, that's your sign right there that they have endometriosis. They're going to come in complaining of a history of the D's, right? Maybe even infertility down there, chronic pelvic pain. I've been seeing for chronic pelvic pain for the last couple of years. I do have dyschezia. I have, painful bowel movements. I've got painful intercourse. That seems to have gotten worse over the last couple of years. The diagnosis is still going to be with that transvaginal ultrasound, and we're going to have that high index of suspicion, especially if they have endometrioma. That is our thing. And if now you can come back and say, dang, I did see you 4 or 5 times for this. I just missed it. Now we finally see this ultrasound, and then we can refer these patients, right, to GYN. So treatment for these patients, specifically for the endometrioma, not for the endometriosis. If that endometrioma is less than 4 centimeters, we can repeat an ultrasound in 8 to 12 weeks. If it is still there, okay, or growing, then they need a GYN referral. Oftentimes they'll go in there and they'll do a surgery and biopsy to make sure there's not any sorts of cancer with them. If they're postmenopausal, remember endometriosis is very estrogen sensitive. Okay, so that's why it increases the reproductive. So postmenopausal patients can still have endometriosis, but less likely. So if they start developing endometriomas in the postmenopausal period, that's concerning that that's cancer. Okay, and so they have some sort of cancer that's causing that. So those patients need a G100 referral. Other things to think about. If someone has multiple septations, I told you from the beginning, multiple septations, bad. So if there's something that they need a GYN referral. If something that says, this is concerning for malignancy, well, we need a GYN referral. Or neovascularization, meaning there is new blood vessels there that's going to something. I can't necessarily see where it's going to, but if I see new blood vessels, it's feeding something. They need a GYN referral. And probably a CA-125. That's associated with that. Alrighty, that is all. Thank you.